Good afternoon. On behalf of the Arthritis Foundation, Upper Midwest Region, and the Lupus Foundation of Minnesota, I want to thank everyone for joining us today. My name is Cheryl Como, and I'm Vice President of Client Services and the Social Worker for the Lupus Foundation of Minnesota. I will be your host for today's webinar, Rheumatoid Arthritis and Systemic Lupus Erythematosus, Diagnosis and Management. Before I introduce our speaker, I want to talk briefly about today's program. The webinar will run up to 1:15. You will see a dialog box on your screen. Please type your questions and comments in this area throughout the webinar period. Time will be provided after Dr. Ytterberg's presentation for Q&A as well. Today's webinar goals include assessment of disease activity in RA and SLE, including clinical features, diagnosis, and treatment. There may be technical difficulties that occur on my end, just as a warning, but I'll make every effort to ensure that the learning opportunity goes uninterrupted. So whether you are new to webinars or a seasoned veteran, here are some tips. On the screen, you see a telephone number. Please jot it down. This is the go-to webinar support services number in the event that you experience technical difficulties on your end. Audio is through headphones or the speakers that are attached or built into your computer. To facilitate sound quality, try to be in a quiet area and adjust your sound as necessary. During the webinar, everyone is on mute status except for the presenter. Type your questions in the box on your screen. Presentation slides will be viewed from your computer screen. If you're having technical difficulties, again, please contact the support number. Keep in mind that the quality of your connection can interfere with slide transition and sound quality at times. Weather can impact the quality as well. At the conclusion of the webinar, a survey will arrive in your email. We hope that you'll take a few moments to complete this survey. And finally, if you require a certificate of attendance, there will be a last slide with my email on it, and I'm more than happy to provide that for you. So without further delay, I would like to introduce our speaker, Dr. Stephen R. Ytterberg. Dr. Ytterberg is board certified in rheumatology. He is a consultant in the Division of Rheumatology at the Mayo Clinic and is an associate professor of medicine at the Mayo Clinic College of Medicine in Rochester. He received his medical degree from Thomas Jefferson Medical College in Philadelphia. He completed a residency in internal medicine at Jefferson University Hospital in Philadelphia and a fellowship in rheumatology at the University of Michigan, Ann Arbor. Dr. Ytterberg's primary areas of interest and research involve two areas, vasculitis and inflammatory myositis, which includes polymyositis, dermatomyositis, and inclusion body myositis. He is a member of the Medical Advisory Board of the Myositis Association and served as a member of the Subspecialty Board on Rheumatology for the American Board of Internal Medicine. He is also the past president of the Board of the Arthritis Foundation, Upper Midwest Region. So thank you for joining us today, Dr. Ytterberg. The floor is yours.
Oh, thank you, Cheryl. Happy to be here. I trust my voice is coming through okay?
Yes.
Okay. And I've got control of the slides?
Yes, you do.
Let's see. Oops. Only they're not moving for me.
Okay. I think I just moved that for you, but...
Okay. Okay, so let's go another one. Nope.
Okay, I'm handing it over to you. Okay, alrighty.
So disclosures, I have no financial relationships with anybody or anything I'm going to be talking about. We're not going to talk about any off-label medication use, and I'm still not controlling these.
Okay, that's strange.
Okay, so what I plan to cover today, we'll talk about assessing disease activity in general in rheumatoid arthritis and lupus, and then we'll talk about the individual disorders. We'll talk about rheumatoid arthritis and then lupus, and talk about clinical features, some of the known pathogenesis, how to assess response and treatment for each of these. Next slide, please. And next slide. So to talk about assessing improvement. So one of the questions that comes up is, after having made a diagnosis of whatever that diagnosis is, and then starting to treat a patient, the question is knowing what is it that's going to be followed? How are we going to know if the patient is improving? And there are a number of things that I count on. I count on things that the patient reports to me, and that's taking an open-ended history from the patient, but also will often use structured tools. In our clinic in particular, we have put together some forms that we and our nurses use when getting a history from a patient with lupus or with rheumatoid arthritis with some key things, and we think that this helps standardize the history that we're getting and the care that we provide. So there are patient-reported features, and then there are things that are learned from the physical examination. So on the exam, how many swollen joints are there? How many tender joints? Has the rash that was there previously gotten better? And finally, we rely on a number of biomarkers. And the term biomarker is used for a test that we think helps predict how the patient is doing. So this could be a number of things. Under the laboratory tests, we'll often follow inflammation markers such as the sedimentation rate or C-reactive protein. As I'll show you when we talk about lupus, patients with lupus can have decreases in some of the blood chemistries called complement. So those are worthwhile to follow as another indicator of disease activity. Sometimes we'll want to follow imaging studies, and this might be x-rays of the hands to know if there's worsening damage in somebody with rheumatoid arthritis, or it might be a chest x-ray to see if an infiltrate or area of inflammation has changed. And finally, we use functional assessments, and so these are standardized tests or sometimes questionnaires that can indicate how active the disease is. We'll talk about some of these as we go on also. Next slide. So one of the things that I try to go over with my patients to help them understand is that just because they have a symptom doesn't mean that their disease is active. And now, why can that be? Well, people get symptoms for a variety of reasons, and we might see somebody with, say, pain in the knuckles and the hands who has rheumatoid arthritis. Now, that could be there because there's currently active disease in those knuckles, or those knuckles might be hurting because there was active inflammation in them over the past 5 years, and now the joint's been damaged. And as that damaged joint is used, it hurts. So just because the knuckle hurts doesn't mean that the rheumatoid arthritis is active and mean that it needs more treatment. We see the same thing in patients with lupus where their creatinine might be elevated because previously they had inflammation in the kidneys, and that inflammation's gone away now, but the creatinine has remained elevated because of the damage that's occurred to the glomeruli. So one of the key things is just because there's a symptom or just because there's a laboratory abnormality doesn't mean that the disease is necessarily active, and it might just be damage. Next slide, please. Now, just to complicate it a bit more is the fact that a symptom might be because of a side effect from a treatment that's being given. So the patient who's on prednisone and has gained weight, that's probably coming from the prednisone and not from the disease. Okay, so looking at the symptoms, I always try to differentiate, is this active disease, damage from previous activity, or a medication side effect? Next slide. One of the important things that has been overlooked, in my view, by physicians in the past has been the importance of the patient's own report. And this is being recognized more and more, and there's now a major effort from the National Institutes of Health called the PROMISE program that focuses on patient-reported symptoms. And they have a website and a whole list of tools for trying to assess patient-reported measures of disease activity. And I think that more and more we're going to see these introduced certainly into clinical trials and likely into clinical care as well. So that was just a reminder of what's coming out there. So let's move on. We'll start to talk about rheumatoid arthritis in general, or in specific. And next. So I put together a case. So here's a case of a 42-year-old woman who's had 3 weeks of pain, swelling, and stiffness in her hands, wrists, and ankles. Symptoms are worse in the mornings and improve by the mid part of the day. She uses ibuprofen over the counter, and this, as she says, takes the edge off. On examination, there's swelling and tenderness of small joints in the hands, wrists, and ankles. The laboratory studies show that she's mildly anemic with a hemoglobin of 11.2. Inflammation markers in the blood, the sedimentation rate, and C-reactive protein are raised. And some of the laboratory tests that we look at with these disorders, including rheumatoid factor, CCP antibodies, and ANA, and I'm going to talk about all of these a bit later, are negative. Next slide. So this woman has rheumatoid arthritis, and sometimes the diagnosis is eased by having some of the positive laboratory tests, that rheumatoid factor and CCP antibody, but those aren't required for making the diagnosis. And what we recognize as rheumatoid arthritis really is a clinical entity, so we expect to see that there's chronic inflammation going on in joints. In this case that I presented, it's relatively short term. It's only been for 3 weeks, and we usually expect it to be longer before making a diagnosis of RA. It affects the synovial joints, so basically the joints that allow movement, the hips, the knees, the knuckle joints, and the fingers. There's a female predominance, so about 3/4 of people with rheumatoid arthritis are female. The peak predominance is in a younger age group, 25 to 50 years. It's estimated to have a prevalence of about 1%, so about 1% of people have rheumatoid arthritis, and it is seen worldwide. Next slide. So here might be a picture of what the hands of this woman that I presented might look like. You can see that there's swelling around the knuckles, around the metacarpophalangeal joints at the base of the fingers, around the proximal interphalangeal joints, the middle set of knuckles, and these are the ones that are primarily affected. This probably isn't the particular patient that I showed, because of the pointer finger angulation suggests that there's a bit of deformity, and this has probably been going on for some time to present that. And actually, just a second. I'm seeing the messages from Cheryl. I am not hearing you.
You're okay. You can be heard.
Oh, okay. Okay. I just saw those typed messages and suddenly thought there was a problem. So going on. So here's another patient with rheumatoid arthritis. And what this shows are these lumps over the knuckles, which are rheumatoid nodules. These tend to occur with longer lasting disease and not be there very early at the diagnosis. And if we can go on again. And here are hands from somebody who's had long-standing rheumatoid arthritis. This is something that we hope not to see so much anymore, and indeed we're not seeing as much anymore as we have better therapies for rheumatoid arthritis. But this would be an example of what I was talking for before, that you can imagine that these knuckles hurt as the person uses them. And the pain at this point may well be because of all the damage that's occurred in the knuckles and not be there because of active inflammatory arthritis. Next slide. We'll spend a little bit of time here. This is to make the point that rheumatoid arthritis is a systemic disease. We always think of it as a joint problem primarily, but in fact it can affect a number of other body parts. So working from the left-hand side of the slide, some patients can get enlargement of the spleen or splenomegaly. There can be trouble in the kidney, amyloidosis, which is an abnormality of blood proteins that can then affect multiple areas, including the kidney, and cause kidney failure. There can be inflammation in the kidneys with glomerulonephritis. This isn't nearly as common as it is in patients with lupus, but has been reported. Patients with a lot of inflammation in their body can develop anemia, and the platelet counts can go up, affecting this from the bone marrow. We'll see some patients with muscle trouble, including wasting of the muscles because of the joint inflammation and pain, or inflammation in muscles. There can be skin ulcers and other rashes. We see some patients who develop what's known as vasculitis or blood vessel inflammation, and this can affect the nerves and cause peripheral neuropathy and foot drop, such as mononeuritis multiplex. On the right-hand side, there are a number of types of inflammation that can affect the eye in patients with rheumatoid arthritis, can cause scleritis or episcleritis, can cause dryness of the eyes, known as keratoconjunctivitis. There can be involvement of the lung, either the lining of the lung, the pleura, with pleural effusions and pleurisy, or there can be nodules or scarring in the lung itself. Some patients develop lymph node enlargement, effusions around the heart, and this amyloidosis can affect the gut. So this is a multi-system disease, although joints are the primary target. And next. And what's been found is that there's an increased risk of coronary artery disease. Patients with rheumatoid arthritis have more cardiovascular events, including myocardial infarctions and congestive heart failure, than people who don't have rheumatoid arthritis. This is presumed to come about because of the chronic inflammation that's going on and the effect that that has on the blood vessels. Next slide. So to look at one study that evaluated causes of death in rheumatoid arthritis, well, they're not all that different from what you might find in the general population, with the exception that probably there's more cardiovascular disease and cardiovascular death in patients with rheumatoid arthritis. But patients with RA can get cancer and have risk from infections, mainly because of the drugs that we use, kidney disease, lung disease, etc. Next slide. So we'll move on and talk a little bit about some of these laboratory tests. So there are two antibodies, or autoantibodies, self-directed antibodies, seen in patients with rheumatoid arthritis. The one that's been around the longest and is best recognized is called the rheumatoid factor. And then there's this newer one called anti-cyclic citrullonated peptide, or for short we call it anti-CCP antibodies. Next. So rheumatoid factor has a sensitivity of about 70 to 80%. That means that about 70 to 80% of people who have rheumatoid arthritis have a positive rheumatoid factor. And in fact, that number is even lower early in disease, so that at the time of diagnosis, this is probably only about 40 to 60%. So what this says is that there's still 20 to 30% of patients with rheumatoid arthritis who are negative for this blood marker. The other problem with this test is it has very low specificity. This means that there are a lot of false positives. There are people with positive rheumatoid factor tests who have no arthritis at all. So the rheumatoid factor can be seen in people with chronic diseases, chronic lung disease, chronic liver disease, chronic infections. We do know that patients with rheumatoid arthritis who have a positive rheumatoid factor tend to have worse disease. They have a higher frequency of these subcutaneous nodules and erosions on X-ray, which I'm going to be showing you. It's felt that the presence of a rheumatoid factor is normal, that we all make it and it's part of the normal immune response. It's just that for some reason in patients with rheumatoid arthritis it's more prevalent. Next. So the other antibody is the CCP antibody. This is more recently identified. Its sensitivity is a little lower, so there aren't as many people with rheumatoid arthritis who have it, but if it's found in somebody with arthritis, it's a pretty good bet that this is really rheumatoid arthritis because its specificity is high, meaning there aren't many false positives. Again, people who have a positive CCP antibody tend to have worse disease, and it's one of the things that would predict that we have to treat more aggressively. Next slide. So this graph simply shows that the frequency, so if you look at the bottom, at the x-axis, this goes backwards. So how many years before diagnosis, or before symptom onset rather, going back 1 year, 2 years, 3 years, etc. And it shows that patients with who are eventually diagnosed with rheumatoid arthritis have positive tests even before they develop symptoms. And as I show in the bottom bullet, this does raise the question of what a false positive test means. Is this somebody we should worry about because they have positive antibodies and may, in fact, in the future develop rheumatoid arthritis? The other takeaway is that at the time of diagnosis, it's only about half of people who have one or the other of these antibodies, so you can't rely on the presence of the antibodies to make a diagnosis of rheumatoid arthritis. Next slide. So because of the trouble with this, the rheumatologists put together these classification criteria. Now the main disclaimer for these criteria, and I'm going to show this with lupus also, is that these are meant for research purposes, not for diagnosing an individual patient. But if I did a study and I said 100 patients were studied who met these criteria, most rheumatologists would accept that more than 95% of them actually had the disease. So the original criteria involved morning stiffness present for at least an hour, soft tissue swelling of at least 3 joints, involvement of small joints, the hands, the PIPs, MCPs in the hands or wrists, symmetric swelling, positive rheumatoid nodules, positive rheumatoid factor, and typical X-rays. Next slide.
Before we move forward, I'm going to put...
click once more, please.
Oh, once more? Okay.
Once more. So this was, I'm sorry, I put it in between there. Sorry.
Oh, okay.
So, and we expected that these findings were present for at least 6 weeks, and that to call RA you needed 4 criteria. Now go ahead.
Okay. We're going to put people to the test. We have a poll, so if we could take a few seconds and if you could respond to the poll.
I was going to answer, but it says not to.
Oh, isn't it working?
No, I'm kidding.
Oh, okay. I was going to say, we have about 40% have voted so far. Still getting votes in. We'll give it about 2 more seconds, and then we'll get going again. Okay. And Dr. Ytterberg, 65% voted for genetic factors.
Good. That's excellent, and that is the right answer. There are no known dietary factors, either something in the diet or something missing from the diet, that are known to be associated with rheumatoid arthritis. There are no specific infections, although this has been an area of research to investigate, but there are strong genetic factors. That said, the genes by themselves don't cause the disease. They probably just make one susceptible. Let's go on.
All right.
Actually, go on one more. That was just to show new classification criteria, but in the interest of time, let me move a bit to talk about the pathogenesis of rheumatoid arthritis. So here on the top panel is a histologic section, so through a joint. So we're looking at probably a small joint in one of the knuckles, and the diagram below it is an image of just a schematic of what a joint looks like. This happens to be a knee, but you see the 2 ends of the bone come together, and that's the pink stuff with space in between it and the picture up above. And then under that you can see the lighter colored cartilage that has the two areas of the bone meeting each other, and it's that cartilage that's nice and smooth that lets the joint move easily. Going back to the lower figure, what's important is that light red membrane called the synovial membrane. This lines the capsule of the joint, and the synovial membrane is important because it provides the synovial fluid, the fluid in the joint, and you need the joint fluid to provide nutrition to the cartilage. But usually the synovial membrane is a very fine, delicate structure lining the joint capsule. Move ahead now. And this shows joints in rheumatoid arthritis. So again, the histology at the top just shows a lot of overgrowth of tissue, and that pink stuff to the sort of center lower part is the cartilage that's being invaded by synovium. And looking at the diagram below, what happens is that delicate synovium that was just a single layer thick is now what's shown as synovial villi. So the synovium overgrows and it becomes inflamed. And there are a lot of lymphocytes and neutrophils releasing bad things into the joint, and the synovium itself grows, and as it shows below, erodes into bone. This proliferating synovium is called pannus. So it's eroding into the bone and really damaging the cartilage and damaging the bone. We go ahead again. So here is sort of a blown-up view of that last picture, and what we see in the rheumatoid joint is a lot of inflammation with lymphocytes, plasma cells, and neutrophils. The synovium grows into pannus and erodes into and damages the joint structures. Go ahead again. Now this is an MRI image of a normal looking wrist joint, and you can see the individual bones are white in the wrist, and the space between the bones is nice and symmetric. So this is a normal wrist on MRI. And go ahead again. And this is an MRI of a wrist from somebody with rheumatoid arthritis with a lot of inflammation in that wrist. You can't see the bones as neatly anymore. In the middle of the picture is all this sort of gray tissue that's eroding into the bones in the wrist and the forearm. So this is all the synovitis. This is that overgrown synovium or pannus that's causing damage to the cartilage and damage to the bone. And this is the target of what we want to quiet down. Go ahead. And we can go again. The arrows are showing erosions. Whoop, back one. So, forward one. Okay, thank you. And this is a plain X-ray, and in this patient with rheumatoid arthritis, there are erosions in the bone, and these are highlighted with the arrows. So we can see them a lot easier with the MRI, but even with plain X-rays, can see this damage to the bone and cartilage that's been caused by the rheumatoid arthritis. And ahead again. And with that, we might see something like this, where there's a lot of deformity and damage that's occurred to these knuckle joints. And this is what we want to prevent. Let's go again. So this brings us to thinking about treatment of rheumatoid arthritis. So inflammation is central to the problem. Click again. And it's the inflammation that causes the symptoms. Click again. We can treat the symptoms with pain medicines, analgesics. Click again. We can treat inflammation with non-steroidal anti-inflammatory drugs, again, or steroids. And this is where steroids work primarily in rheumatoid arthritis to quiet inflammation. Click again, and again. But the problem with rheumatoid arthritis really comes about because this is an autoimmune disease. So the immune system, instead of being the good guy trying to clean up viruses or attack and prevent viral infection or bacterial infection, gets misdirected and attacks the body itself. Click again. So what we want is something that quiets the immune system. And in rheumatoid arthritis, these drugs have classically been called disease-modifying anti-rheumatic drugs, or DMARDs. Click again. So there are a number of DMARDs that have been used over the years. These are some that were used 30 years ago when I got into this field that we don't use any longer. So back then we used injectable gold compounds. There were two called myocrysane and solganol. We had an oral gold pill, and we used something called D-penicillamine. I think it's been more than a decade, probably a decade and a half, since I've given any patient any of these. Again, these are drugs that we continue to use, so these are called non-biologic disease-modifying anti-rheumatic drugs. And hydroxychloroquine or Plaquenil is one that we'll use for mild disease, as is sulfasalazine. Methotrexate's the drug that we probably use the most for rheumatoid arthritis. Some patients will be on leflunomide or Arava, and less frequently azathioprine or Imuran. Go again. More recently, what have been developed are what are called biologic DMARDs, and they get this name because they're generally involving cell biology techniques to identify targets and then produce targets. So these drugs are really aiming at much more specific parts of the immune system. The old drugs, the older drugs, the methotrexate, the Arava, have more general effects on the immune system, while these target very precise parts of the immune system. So the first of this group that came out were the so-called TNF, tumor necrosis factor inhibitors. This is one of the key signals in the immune system that's active in rheumatoid arthritis. And there are now 5 of these on the market. 4 of them are given as self-injected medications, and 1 is given intravenously. And that is one of the aspects of all of these biologic agents, is that they have to be administered parenterally. They're either given as a subcutaneous injection or an intravenous infusion. So we now have 5 of the TNF inhibitors. There's a drug called anakinra or Kineret that inhibits a molecule called IL-1, interleukin-1. A relatively newer one called tocilizumab or Actemra that targets another interleukin called IL-6. There are some that interfere with how T cells, one of the main parts of the immune system, signal each other, and one that interfere with how B cells, another one of the main parts of the immune system, act. Go ahead. So this schematic gives some idea of these, very, very rough, I'll admit. So this APC is an antigen-presenting cell. We think that the T cells are the important lymphocytes in the immune system active in rheumatoid arthritis. To turn the T cell on, an antigen-presenting cell is here presenting the orange antigen to the T cell. Once that interaction occurs, a whole host of these inflammatory cytokines or signals are released, the TNF-alpha, interleukin-1, interleukin-6, etc. These then have effects on the synovium, which then causes the cartilage damage, changes how the blood vessels can grow because of the adhesion molecules. So where these drugs work are on these various molecules. So click once. So the TNF inhibitors, once again, get rid of the tumor necrosis factor. Click again. We'll just, oops, oh, I'm sorry. Oh, no, go ahead. I wasn't looking at my notes and forgot what was next. So this, again, is the idea that there are 5 of these on the market now, 1 given intravenously, the others given subcutaneously. They have various dosing schedules. Some patients prefer one to another just because of the frequency or infrequency of the dosing. So then there's anakinra that targets IL-1, and again, tocilizumab targets IL-6, and again, abatacept interferes with the stimulation of the T cells, and again, rituximab gets rid of B cells, and again. So those are the types of drugs that we use. The question, we'll get back to one of the things I started with, and that is how do we know if patients have improved? There are a number of disease activity measures that have been introduced for rheumatoid arthritis. The first one was called the ACR, American College of Rheumatology, 20, 50, and 70. And I'll show you something about that. And more recently, one called the DAS score, the Disease Activity Score, and now there's the Simplified Disease Activity Index and the Clinical Disease Activity Index. We try to measure these in patients we see with rheumatoid arthritis to get a feel for whether they are improving with the treatment that we give them. Click again. Just click again, just in the interest of time. So this compares the various outcome measures that are incorporated into each of these. So what people have felt to be important for rheumatoid arthritis are the number of tender joints that are present, the number of swollen joints, the patient's rating of their pain, the patient's rating of their overall well-being, the physician's rating of the patient's overall well-being, this HAQ score that measures disability, and then inflammation markers in the blood. So again, it gets back to that idea that we try to use a number of different aspects to gauge whether somebody's improving or not. And this shows which of them are incorporated into which of these different measures. Let's go ahead again. Just as an example, this was a study that was protocol-driven, and as shown in the second bullet, they measured these DAS scores at monthly intervals, and if the patient had not improved, the strategy was you increase the treatment. And it showed that if they intensively monitored these DAS scores, the disease activity dropped because the patients were being treated more aggressively. So this is one of the advantages of having an objective measure of the patient's disease activity. Go ahead. So these are the laboratory measures that we tend to follow in patients with rheumatoid arthritis. Inflammation measures, including the sedimentation rate and C-reactive protein, the hemoglobin, the platelets, and the albumin. Measuring rheumatoid factor and CCP antibodies doesn't add anything to the care of patients with rheumatoid arthritis after they've already been measured once and found to be positive. Go ahead. So my summary of this brief talk about rheumatoid arthritis, to think that this is an immune-mediated inflammatory condition that targets joints but has systemic features. We're understanding more and more about the pathogenetic mechanisms. As we understand those mechanisms better, I think we're going to have better treatments. We already have new, more effective treatments in the past. And this idea of targeted therapy and having objective measures, I think, is key. There are ongoing efforts to find even newer biomarkers. So let's go on.
Dr. Ytterberg, I do have a question.
Yes.
The question is, do you know why it is that more women than men get arthritis?
We don't know that. There have been a lot of conjectures, whether it has to do with hormones is one thought. There's also been some thought that it may be related to pregnancies, and there is one set of theories that fetal cells get into the maternal circulation and vice versa during pregnancy, and this may actually be a stimulus to the immune system to cause autoimmune diseases, because it's been an observation that autoimmune diseases are more common in women than in men, but all speculation. So we'll move on and talk about lupus. Go on. So here's a case, a 32-year-old woman with rash and joint pain. Her symptoms began after a period of prolonged sun exposure 1 month earlier. She has rash on sun-exposed areas of her face, chest, arms, and legs, and she has arthritis in a number of joints. Go ahead. Oop, back up one. So her blood counts her white count is low, and lymphocytes in particular are decreased. The urine sample is normal. The ANA test is positive, and there are antibodies toward double-stranded DNA. Sorry, here, I just kicked over my water bottle. The other antibody panels, the ENA antibody panel shows antibodies toward this SSA or Rho, and complement values are low. Go ahead. So why is this lupus? Well, she has many of the typical features of lupus. She has rash, and especially a photosensitive rash, arthritis, low white count, positive ANA, other autoantibodies, and the low complement. This is about the best we can get for making a diagnosis of lupus. Go ahead. So what is lupus? I think of lupus as a multi-system, immunologically mediated, inflammatory condition of unknown etiology that typically affects young women and is characterized by the presence of autoantibodies. Go ahead. So for good or bad, lupus has a lot of potential manifestations, and it seems that people with a lot of different things get referred with the question of whether they might have lupus. So we see people with constitutional findings, fever, chills, weight loss. We see patients with Raynaud's, fingers turning blue and purple on cold exposure. We see mucocutaneous disease, including rashes and mouth sores. And if we click ahead, so here's a patient with a typical malar rash, this red rash that covers the cheeks and nose. And one of the major observations is that this does not involve the nasolabial fold, that crease going from the corner of the nose down to the corner of the mouth. Go ahead again. And again. And we can probably do one more and it'll have the name there. And this is a discoid lupus rash. This happens to have a malar distribution but extends down over the nasolabial fold. And the features of a discoid rash are that it is active and has heaped up margins at the edges of the rash, whereas the center of the rash actually can be scarred, and that's what's shown on the left cheek here. That pink area is actually scar from this discoid rash. And ahead again, and again. Okay, and so this is a subacute cutaneous lupus rash. This also has the activity at the periphery, so that's the edge of it that is heaped up and active, but it isn't, it's a little more active than the discoid rash. And again. And here's a patient with vasculitis, with inflammation of the blood vessels that causes this sort of blotchy rash that happens to be on the palm. Go ahead again. In addition, we go back one. Can see joint involvement, musculoskeletal involvement, kidney involvement, changes in the blood counts, cardiovascular disease, lung inflammation, and even central nervous system inflammation. So lupus really is a multi-system disease. Now we'll go again. So this graph gives is from one study that gives an idea of sort of the frequency of these various manifestations and when they show up. So green are things that are present at the onset of disease, and blue any time over the course of the disease. So you see that the constitutional things and joint things are among the most common. Rashes are very common, but kidney involvement is fairly common as well, probably being present in more than half at some time over the course. Go ahead again. Just as with rheumatoid arthritis, investigators put together criteria for the diagnosis of lupus. And this is, I think, even more important for lupus than rheumatoid arthritis because of the diverse manifestations of lupus. So the classic criteria for lupus that are now more than 30 years old are to have a malar rash, discoid rash, photosensitive eruptions, mouth sores, arthritis, serositis, meaning pericarditis or pleurisy, kidney involvement, neurologic involvement, hematologic involvement, and the last two are laboratory tests, positive ANA, and the immunologic disorder means some other autoantibody. Click again. The disclaimer always is that these are classification criteria. These were developed for research study purposes and not to diagnose an individual patient, although we often use this as a guide for the type of things that we expect to see with a patient with rheumatoid arthritis. Go again. So the anti-nuclear antibody test is the key test in patients with with lupus. So the anti-nuclear antibody means that the patient has developed antibodies directed toward things contained in a normal cell nucleus. And there are a number of things in the nuclei that can be recognized. This can include DNA, which can be native or double-stranded DNA, as well as denatured or single-stranded DNA. Then there are these what are termed saline extractable nuclear antigens. And these are ordered or viewed as the ENA, the extractable nuclear antigen panel. And patients with lupus can have antibodies toward other things. So the ANA is highly sensitive for lupus. Virtually everybody with lupus has a positive test. The problem is that it's not specific. It's not diagnostic for lupus. The other thing to know is that there are different assay techniques for lupus. Should we?
Yeah, before we move on, I have another poll to launch, and I'm going to do that right now. Okay, you can start answering that question. I'll give it about 10 more seconds. Okay, people have paid attention. 88% said false.
That's very good. That is very correct. I won't say true. It's correct. Let's go ahead.
Oops.
Actually,
did
go
that
ahead.
do something? Okay.
No, go ahead and click again. Actually, we'll just keep clicking through here a few times. This just shows some of the different patterns of the anti-nuclear antibody test. And the fact that there are different patterns that show up mean that various patients with lupus identify different things in nuclei, so they have different specificities of their antibodies. But let's go ahead again. I'll not dwell on that. So in addition to lupus, other things can cause the ANA to be positive. So patients with other connective tissue diseases, things such as scleroderma or polymyositis or even rheumatoid arthritis, can have a positive ANA. Patients with other autoimmune conditions, multiple sclerosis, autoimmune thyroid disease, can have a positive ANA. There are a number of medications, classically hydralazine and procainamide, but minocycline, INH, and others can make the ANA turn positive. There are a number of infections that can make it positive, parvovirus, hepatitis C, and HIV. The ANA can sometimes be positive in patients with cancer, and we probably see more positive ANAs with increasing age. And sometimes we just don't know why the ANA is positive. We'll go ahead again. So once seeing a positive ANA, if there's suspicion for lupus, what's important is to check for other autoantibodies. So we often check for antibodies toward double-stranded DNA, and as shown here, about 40 to 50% of patients with lupus have these. So it's not nearly as sensitive as the ANA. And then the last four listed, the SM is anti-Smith antibodies. This SSA/Rho can be seen in Sjogren's, as can the SSB. And then this RNP antibody. Those last four are the ones that I referred to previously as ENA, or extractable nuclear antigen antibodies. So with the ANA and concern for lupus, we then go looking for other autoantibodies. Next slide. This slide is similar to the one that I showed about rheumatoid arthritis. This was a study done where they looked at patients in the military who had annual physical exams and blood stored at those exams, and they identified patients who ultimately developed lupus and were able to go back into the freezer and pull out the blood samples from their earlier examinations. And what this shows, we don't worry about the colors, but what it shows is even before the diagnosis of lupus, or on the right, even before the first manifestation, even before the first symptom, patients with lupus, by most had autoantibodies that were showing up already. And as I said, with rheumatoid arthritis, this does raise the question of whether this means there are really false positive tests, or if you keep following patients, you're going to see that they develop an autoimmune disease. Let's go ahead. Now, I want to leave time for questions, so I'm going to go through some of these a little quicker. Let me just say that autoantibodies in lupus cause trouble, that there are some specific antibodies that can make the red blood cells go down and cause hemolytic anemia. It's deposition of antibodies and the antigen they recognize as immune complexes that seem to hurt the kidneys and cause arthritis. Go ahead again. When I follow somebody with lupus, I follow the double-stranded DNA antibodies and the complement levels, because they tend to change with disease activity. So if you follow from the left, the blue shows that it starts at a high level and somebody's in remission and the disease is quiet. And as they're moving toward active disease, the complement levels tend to go down, and with activity, the levels are lower than when they were when the disease was quiet. The inverse is seen with the DNA antibodies. Those tend to appear and go up during active disease. So we tend to follow these. And the question always is, in that gray zone, what happens to the patient who really hasn't developed symptoms but has the DNA antibodies going up and or the complement coming down? And in those circumstances, we will, I tend to just watch the patient more carefully, maybe see her back sooner. Let's go ahead again. Now, let's go ahead again. I'm going to skip and again. These were just some new research about studies linking interferon to lupus, so that interferon may be a signal that's involved in lupus and may represent a target of something. So let's click through some of these again, because this is just what I showed you in rheumatoid arthritis. And keep going here. And again. So to treat the symptoms, we might again use painkillers. We use things that dilate blood vessels to help Raynaud's. That doesn't treat the underlying disease, it's treating the symptoms. To treat the inflammation, again, we're thinking steroids or non-steroidals. And click again. And click. And click. But really, we want to quiet this autoimmune process that's driving lupus. And here, we'd just call these immunosuppressives, although methotrexate's the same thing that we called a DMARD for rheumatoid arthritis, but it's the same concept, that we can often quiet the inflammation of lupus with prednisone, with steroids, but the issue is how much prednisone does it take, and as we try to taper the prednisone, are we doing enough to quiet the autoimmune stuff to let the prednisone come down? So click again. So this shows some survival. This is historic data from back in the 40s, the 50s. And so here's survival way back then, and click again. And with the introduction of prednisone, and click again. And then after the introduction of immunosuppressive drugs. So we've definitely seen an improvement in survival in patients with lupus as we're able to do more. And click again.
Do we have a poll here, or is there more on this slide?
You can go ahead and do it now.
Okay. We're going to launch one more poll, and here it comes. Okay, we'll give it about 10 more seconds. Okay. We have, well, the question was, which of the following is the side effect of prednisone? And check all that apply. And so 50% cataract, 63% stated diabetes, 56% said GI bleeding, 56% hypertension, and 63% infection. So I'll let you answer that, Dr. Ytterberg.
So actually, I view it that it's all except GI bleeding, and the GI bleeding is controversial. Now, maybe it was the wording. Not everybody on prednisone gets these side effects, but all of these are things that can be seen with prednisone. As I said, with GI bleeding, probably the data suggests that prednisone by itself isn't a risk factor, but when combined with anti-inflammatory drugs such as ibuprofen or naproxen does increase the risk.
Great.
So let's go ahead. So this is something I draw for patients, and that is that not all lupus is the same. And to my view, there are patients with more severe lupus over on the right with nephritis and central nervous system involvement. There are people with milder lupus on the left who may just have rash, arthritis, Raynaud's phenomenon, or fatigue. And then I've got a middle group of people who drop their blood counts or have involvement of heart or lungs. And so I think of gauging the treatment based on how severe things are. If it's more severe, you've got to treat more aggressively. You're thinking high-dose steroids or cytotoxic drugs. On the lower end, it might just be anti-inflammatory drugs. Anti-malarials, Plaquenil, hydroxychloroquine, is usually recommended for virtually everybody who has a diagnosis of lupus. And that's one thing that's probably changed over the past several years. I'm thinking that even in patients with severe disease, it probably adds some benefit. So let's go again. And again, mindful of the time and want to leave some time for questions. So I kind of have viewed that we use non-steroidals for constitutional symptoms, musculoskeletal symptoms, and serositis, pleurisy. Steroids can really be used to treat almost anything with lupus. And the main question is how much you have to use and how bad the side effects are going to be from prednisone. And as you taper the prednisone, is the disease just going to come back? And that argues for quieting the immune system. Click again. And then, I probably should have updated this, but didn't change to put the anti-malarials or Plaquenil all the way over, even for major organs. And we use immunosuppressive drugs in these kind of combinations. And go again. As with rheumatoid arthritis, I think that the direction of treatment of lupus is much the same, and that is to try to identify mechanisms that are involved in the pathogenesis and to have things that target them. So this abatacept, which I'd shown with rheumatoid arthritis, which interferes with the signaling and activation of T cells, has potential for lupus as well. Getting rid of B cells, which seem to be a more important player, has been tried with lupus. Studies of CD20 targeting antibodies, rituximab, were not effective, but another strategy that targets B cells with belimumab or Benlysta was effective and is an approved treatment for lupus now. There have been some studies with various of these biologic agents that target the interleukins and other cytokines. And one of the slides that I went by quickly was about the interferon alpha, which is a part of the immune system, which is an interesting target that may be directed or targeted in the near future. And again. So as with rheumatoid arthritis, we try to differentiate disease activity from disease damage. when I see somebody with lupus or actually any of these autoimmune diseases, Cheryl mentioned that my research areas focus on myositis and vasculitis. Why am I talking about lupus and rheumatoid? Well, because they all share so many of the same underlying mechanisms, and we use the same autoimmune targeted drugs to treat them. We've got the same strategies about trying to differentiate activity from damage, etc. And especially in lupus, we think about paying attention to risk of infection, thinking of checking bone densities for osteoporosis. Like rheumatoid arthritis, women with lupus seem to have an increased risk of early coronary disease. Check on drug side effects and quality of life. Go ahead. And as with rheumatoid arthritis, there are a number of disease activity tools. Again, there's this whole alphabet soup of different tools that have been developed. We tend to use the SLE in our practice, the second one up from the bottom. And ahead again. And when I see a patient with lupus, I typically check a CBC, creatinine, and urinalysis. I check inflammation markers, those complement values, and double-stranded DNA, and then tests that are specific for the individual drug that the patient's on to look for toxicity from the drug. Again, so down to the last two slides. So the rheumatoid arthritis and lupus have elusive causes. We don't know what causes them, but pathogenic mechanisms involved are being better understood. We have these criteria for rheumatoid arthritis and lupus. These can help us think about individual patients, but they were really meant for classifying patients for research studies. And then thinking of activity scores as being used for rheumatoid arthritis, and I think we're increasingly going to be seeing the use of activity scores for lupus and trying to see that the lupus activity is brought down as well. And final slide. And treatment of both rheumatoid arthritis and lupus is moving from non-specific therapies directed toward inflammation and immunosuppression to more targeted therapies, again, trying to suppress inflammation and suppress the immune system, but it's really the understanding of the mechanisms and understanding the individual patient's disease activity and risks that are helping us. And the search continues for optimal biomarkers for diagnosis and assessment. And
we do have some questions for you. Here,
okay.
Let me get to them. This question goes back into regarding the RA section, and it states, is the ulnar drift shown in the early photo typical of RA versus OA?
So ulnar drift is one of those clinical features that's often felt to be a feature of rheumatoid arthritis, and I think definitely more so for rheumatoid arthritis than osteoarthritis. I wouldn't say it's 100% absolute. The cause of ulnar drift in rheumatoid arthritis is probably because of the inflammation at the wrist, and it's the wrist inflammation and tenosynovitis of the extensor tendons that's allowing the ulnar deviation.
Okay. Another question is, does a patient have to have a positive ANA to be classified as having lupus? It's a two-part question. And can they meet the criteria with 4 of the other categories?
Yeah, so it's an excellent question. The way the criteria were set up is that indeed if somebody met the 4 criteria with a negative ANA, that could be called lupus. A lot of people, though, would be very suspect of that patient and be suspicious that the patient doesn't have lupus. Now, that said, there's been controversy in the rheumatology literature about the ANA tests. One of the slides I went by quickly showed the patterns of positive ANAs. So the original tests were done as an immunofluorescent technique, and many immunologists think that that should be the gold standard. Many labs nowadays have gone to what's called a solid phase technique for the immunoassays because it's less time and labor intensive and it's a cheaper test to do. But it's raised a question that we may actually be seeing false negative tests. It used to be that we worried mostly about false positive tests, but with the current way the techniques are done, we have to wonder about that. So I would say that yes, you can have a negative ANA and have lupus, but I'd be very suspect about the diagnosis of lupus in that patient.
Okay. This is more based in a question. There may be theories around it or actual research. Is there research or prevalence in when they're looking at, nature versus nurture in diagnosis of lupus? How much of it's environmental? How much of it is genetic? And the possible triggers?
Yeah, so again, very good question. I think it's not just lupus, but it's all of these diseases. And I have to admit that off the top of my head, I don't know the exact figures, but there are, and this is true not only with rheumatoid but lupus, that if you have a twin, if you have I'm just blocking. A fraternal twin. What's the other word? I'm just my mind just went blank.
Oh, no. What is that? Identical.
An identical twin. Thank you. That if one of an identical twin has lupus, there's a much greater risk of the identical twin having lupus than if it's a fraternal twin, but still it's not 100%. So it suggests that there is something in the environment that triggers these. And these same types of things have been observed with rheumatoid arthritis and other autoimmune disease. And it's probably that you've got to have the right immunogenetic makeup to be able to respond to the right trigger. And maybe there are multiple triggers. But how much is responsible? The genetic studies often say that they can that the genetic things kind of account for maybe 30% or 60% of the total risk for developing rheumatoid arthritis and lupus. But I've got to admit that off the top of my head, I don't know those figures, which is more prominent.
Okay, great. Another question. Does Lyme disease also cause positive ANA and other antibodies? And what about fibromyalgia as well?
So Lyme disease doesn't typically cause a positive ANA or the other autoantibodies. The parvovirus is one that we often worry about because it can cause rheumatoid factor and ANA to turn positive, and people who develop adults who develop parvovirus frequently get arthritis. It's often a transient form of arthritis, but that said, I've seen somebody who had very clear-cut parvovirus who eventually basically had clear rheumatoid arthritis. But Lyme, no. The other is that fibromyalgia, the answer is no. Patients with fibromyalgia don't have or don't develop autoantibodies, at least any more than you'd see them as false positive tests in the general population.
Okay. Do you feel that long-term narcotic use is beneficial versus analgesics? I'm not certain if this came under RA or if it came at the end.
Yeah. So there's controversy about that. So basically the schematic that I showed you with that for treatment of both of these diseases, going from autoimmune on the left to inflammation to symptoms, the question is if you need something to treat the symptoms, at what time do you end up going to an opioid analgesic rather than a non-opioid analgesic, and what are the benefits and risks? In fact, one of my colleagues here just reviewed the literature about rheumatoid arthritis and noted how poor the literature is, that the studies that are out there are really quite old and not of very good quality. And I think that the studies are even poorer with lupus. Excuse me. So it's all the question of benefit and risk of, if you're not getting enough pain relief, at what point do you think of using a low-dose opioid analgesic? When I was still at the university in the VA before moving here, we had done some studies looking at our population of rheumatoid arthritis patients treated with low-dose opioids, and found that they were relatively safe. But it's always the question of, how safe is safe.
Great. I have another one here. States you commented on the medications that treat these diseases for both. But is there research for a cure? And if so, how far in the future is this? Do you think one needs to understand the origin or the cause of the disease to cure it?
These are all great questions. So with autoimmune disease in general, as I tried to say, we've got this concept that you need a couple of things going on. You need to have the right genetic background that makes you susceptible, either susceptible to whatever trigger it is, whether it's the sunlight for lupus or an infection. And these are a couple of things that have been raised as possibilities. But if you can't change the genes. You might be able to change what genes are expressed, which is a relatively new concept. The genes, just because you have the gene doesn't mean that it's actively expressing itself and making the proteins that come from it are being made. So in the future you may hear about being able to down-regulate genes that are there without replacing genes. Might be one concept. The other is if you identify, say, an infectious cause in the environment, I would wonder if you don't start thinking about a vaccination that then might prevent the infection and ultimately essentially cure the disease. Maybe it's more preventing the disease rather than curing it, because once the immune system seems to have been triggered, there are some autoimmune diseases that I tell my patients are single-shot things, that it's one flare-up and after that quiets down, the disease seems to be gone. If it's something in the environment that triggers it, presumably that trigger went away. But there are other autoimmune diseases, and rheumatoid arthritis I think is the classic one with this, where it seems something has changed the immune system and changed it so the body's reacting toward itself or against itself. And it seems whenever we try to taper medications with rheumatoid arthritis, things will flare up. I think it's more often that we can taper and maybe discontinue drugs in patients with lupus more often than rheumatoid arthritis. But again, to my mind, it's the question of, is there something that's still there stimulating or triggering the immune system, or is it that something's changed the immune system that is a permanent thing?
Okay, and I have one final question. Are there any items you could, is there anything that you can do to prevent occurrence of autoimmune disease? Meaning, if there's a strong autoimmune disease in the family, are there things you could do to help reduce the risk of a variation of the disease to occur?
So this is the kind of question that I answer my patients. I'd be rich and famous if I knew the answer to that. Just not meaning to be trite about it, but it really gets to the question of, can we understand that interplay of, can we understand what the trigger is and the interplay of the trigger with the host factors that bring on disease? And I think we're still a good ways from that. I will add that we know that autoimmune diseases tend to run in families, but they don't always breed true. So you might hear that, in fact, I saw somebody today with dermatomyositis, basically a cousin of lupus. The rashes can look exactly the same, the biopsies can be the same. But she noted that on her mother's side of the family were several people who had rheumatoid arthritis and somebody with lupus. So it's that idea that there are risk factors, but I tell my patients that just because you've got this disease doesn't mean that you avoid having children, because it's not something that's inherited directly from mother to daughter to granddaughter, but there is some risk, but we don't know what it is that then triggers it. So I don't know what to do to prevent is the bottom line.
Great. Well, this was a wonderful period of time. And, on behalf of the Arthritis Foundation, Upper Midwest Region, and the Lupus Foundation of Minnesota, Dr. Ytterberg, I want you to thank you for taking time from your busy schedule. This was an amazing presentation, so thank you so much. And I want to thank the Arthritis Foundation as well for partnering with the Lupus Foundation on this webinar. And finally, I definitely want to thank everybody for joining us today. You really did have some wonderful questions, like Dr. Ytterberg pointed out. And we hope that you have enjoyed today's webinar. You will receive a survey via email, so I'm asking that you complete this. We use this to improve our programming as well as offering new programming. If you need a certificate of attendance, my email is on the screen right now, so please send that out, and I will make sure that you get a certificate for attending today. So on behalf of all of us here at the Lupus Foundation, Arthritis Foundation, and Dr. Ytterberg, thank you for attending, and have a great afternoon.